So my name is Kanmi, Kanmi. I'm a psychiatric nurse practitioner here. I've been with Integrity House for 7 years now. I think I started in 2017, seeing patients in the Willow Tree outpatient, then subsequently, in Newark and in Secaucus. So it's been a great experience, and I really enjoyed being here and participating in the care of the patients that we all love. So I look at, my experience here as a collaborative one. So, you know, working together with not just the medical staff, but, also with the counselors. I think it's made my experience here a great one. Also, even some of the patients that have been discharged from here, some of them have, reached out to me in my private practice, to see the journey from somebody who comes in from a short-term program to, long-term to, halfway house, mommy and me, outpatient, just to see the progress. I think it's rewarding, and I'm sure it's rewarding for all of us. So the topic today is stimulant use disorder. And I wanted to talk a little bit about how did I come up with that? How did I feel that, stimulant use disorder is important? So for the past 2 decades, I think there's been a concerted effort nationally and globally on, treatment of opiate use disorder. And I think we've come a long way. We've made a lot of strides in doing that. I'm just trying to get my slides to show up here. Let's see. Can you help me out here? So the slides will be available, by the way, at the end of the session. I just don't see it. So now I talked about opiate use disorder. That's been in the limelight. Everywhere you look, we've talked, ad nauseum about opiate use disorder. Now we've made a lot of considerable progress. Increasingly, I'm finding that when I see patients, when they come in with opioid use disorder, which we have interventions for, we have the Suboxone, we've got the methadone, we have Sublocades now. So different formulations if a patient is not able to take oral medications because of convenience or adherence issues. We've gone as far as even giving Sublocade injections, which people find fascinating and beneficial. But in the past 1 year, one thing that I've noticed is that a lot of the patients that are coming in to see us are on methadone and they're on Suboxone. So even though they're free of opioids or they're not using, and I mean, sometimes the patient will come in and will say, well, I'm here for opioid. What are you here for? I'm here because I'm using cocaine, I'm using crack, I'm using methamphetamine. And that question is triggered for me once I see that a patient is already on methadone. Because I say, well, did you relapse because your methadone or your Suboxone is not helping? No, well, I'm not, I'm clean. They will say, well, I've been free from opiates since, 10 years ago. So I'm like, well, what's going on? So one of the things that I feel that we're missing is as much as patients who are being treated for opiate use are successfully in a lot of cases being treated, we find that a lot of those patients are not drug free, and I think sometimes that's what we miss. So, somebody's on Suboxone, they're good, but we're not saying, are they substituting those opiate use for something else? And in a large extent, I'm finding that that's becoming very prevalent, and that those patients, even though they're not using heroin, they're not using fentanyl, but they are just, using something else, and that we're not paying attention to. And one of the issues that we've had is that there's been medication-assisted treatment for opiate use, just like there is medication-assisted treatment for alcohol use disorder. So we have the naltrexone, we have the Vivitrol, but up until now, there's not been a lot of interventions for patients who use cocaine or who use methamphetamine. So I'm going to go over some data. So the rates of substance stimulant use disorder has been on the rise. And then also with the rates, also the overdose deaths among patients who use cocaine, methamphetamine, amphetamine, and prescription stimulants. So what are the prescription stimulants, you might ask? You know, we've got Adderall, we have medications like that. And approximately 33,000 Americans died from an overdose involving psychostimulants in 2021. And that has been considered to be a 37% increase from previous years. So there's 30% of all drug overdoses in 2021 involved the use of psychostimulants. Now, patients may say, well, we're not using fentanyl, which, you know, it has been devastating now, but you find that even the cocaine, and some people also find that even people who smoke marijuana, that there's some fentanyl. So there's a crossover of some of this medication. You know, so you may say, well, you know, I'm only, you know, doing cocaine, I'm smoking crack, but you may get some fentanyl in it as well, which is, you know, very devastating. Now, some of the issues, medical issues related to stimulant use are the, you know, risk of HIV infection, risk of a viral hepatitis, infective endocarditis that we may not be looking at immediately, but it is, you know, it is there. So now, how do we assess patients who are using stimulants? It is imperative to first identify that if there are any emergent biomedical or psychiatric symptoms, such as acute intoxication related to the overdose, you know, and making appropriate referral. So stimulant use disorder stimulates the nervous system. So you find patients who find out that they're, you know, withdrawing, or, you know, will end up in psychiatric hospitals for psychosis from drugs. I've seen 2 patients already this week. I think I saw a patient earlier this week who the police brought to the emergency room because they found him on the street dancing. I mean, I made a joke. I said, well, you know, he's from another country. I said, well, were you a dancer back in your old country? He said, no, yeah. Because I read his hospital report, and they said they found him on the street dancing naked, and he was brought to the emergency room, only to be found that it was, you know, a psychosis that was stimulated because of methamphetamine use. So really a diligent health assessment. How are we assessing these patients, and what are some of the things that we are doing? Is it an emergent care that is required? I also, prior to doing psychiatry, I was a neurology nurse practitioner, and I was one of those people that will go into the emergency room to assess patients. So most patients that present to the emergency room with neurological deficit, sometimes simulating a seizure, simulating a stroke. I mean, some of it could be drug induced. So we would have patients coming into the emergency room. So you have risk factors for stroke, you know, hypertension, diabetes, you know, age, smoking, but stimulant also could precipitate an acute neurological event. So this was an experience that I would never forget. So I went into the emergency room. This was a young woman that was brought in via ambulance. And by the time that I saw her, evaluating that to see if she had a stroke, she was already waking up from the, you know, from the stimulant that she used. And I was asking her questions that she felt the emergency room doctors already asked her. She became agitated, you know, pulled out IV, blood spilling everywhere, running out. I mean, so definitely there's a danger associated. There's a risk not only to the patient, also to the caregivers. Now, prior to the interventions which had just recently been promulgated by the you know, the American Academy of Substance Use, interventions for stimulant use have been reserved only to managing symptoms and also behavioral modification. So usually there's a contingency management is one of those interventions that's been utilized for stimulant use disorder. So contingency management, those of you guys that are those of our counselors and that do a great job, you're definitely familiar with this approach. Contingency management is considered to be the most effective treatment for stimulant use disorder. And it can be combined with other interventions and therapies, including community reinforcement approach, cognitive behavioral therapy, and also using the matrix model. Those I'm going to talk about at length, but what I want us to focus on are the new trends, which I believe is an opportunity that we didn't have before. So usually when a patient comes in, when we talked about the alcohol, the opioids, there's a routine, I mean, that we know the go-to. Whether it works or not, I mean, it's debatable, but I find patients of mine who are on Suboxone, Sublocade, and it's been a lifesaver. And I see patients who would say to me that, thank God that I'm on this medication. That's what's kept me going. And I've seen them being able to, go back in the community, take care of their family, have a meaningful employment and do well, and they thrive. So we have that, like I said, for opiate use disorder. But recently now, some of the things that's coming along, what are some of the treatments for stimulant use? Well, in terms of treatment, I'm not talking about therapy now. What are some of the medication intervention for stimulant use disorder? So a recent article came up with some of the ideas, and those of my nursing colleagues will attest to this, that we have patients who sometimes we learn from our patients. We have patients who will request for certain medications, and it makes you wonder, why is it the patients who use stimulants, the preference in terms of medication intervention when they would ask you would be some antidepressants that are stimulating. Is it a coincidence? But I think the patients sometimes know a lot more than we do, and they're far ahead, and they know what resolves their cravings. So one of the recommendation, not FDA approved, but research studies have shown that these medications that I'm going to go over might be beneficial in helping. So, and what I feel that it does is that as providers and as caregivers, it gives us an opportunity not to just say, well, you use cocaine, you use meth. You can, I mean, Suboxone is not going to help you, that we don't have anything for you but therapy. But to be able to look outside of a box and say, hey, these are some interventions that may be beneficial. So one of such medication that has been shown recently to be beneficial in reducing craving for cocaine use is a medication that a lot of us know and we love. It's Wellbutrin. So Wellbutrin was shown to be able to promote cocaine abstinence, and we know most of our patients, like tobacco, nicotine addiction is sometimes concurrent with even in mental health. So patients stop using drugs. The patient say, oh, when I was in jail I wasn't smoking, but now the stress, I'm smoking. So Wellbutrin is selective serotonin and norepinephrine reuptake inhibitor. So the norepinephrine part kind of helps with the stimulation. So a lot of the patients who take Wellbutrin have been shown to have decreased cravings for cocaine. So when we offer medications, when we offer interventions for these patients, knowing their drug of choice, knowing what they came in with, I think it's important for us to be able to present an option and say, hey, well, you have depression as well, you smoke, and you have, stimulant use disorder. Wellbutrin might be a medication that is beneficial. I know some of our nurses are looking, some of our staff will say, well, what's the problem with that? I'm going to discuss that because there could be challenges also to all this intervention. And I think I'd like some feedback also on how we can address those challenges.
Omni, I'm sorry to interrupt. Do you want me to share your slides? They're not.
Yes, please. I
Okay.
can't. I was looking for it. I
I'll
couldn't.
do it. You just let me know when you want me to move to the next one.
Here we go. Let's see.
Is this where you are?
This is where I am. Yes. Am I able to advance it from here?
You may be able to try it. I don't think so though, because I think I'm the one sharing them.
Okay. So we'll just. So this is where we are. So Wellbutrin is one of those medications that's been shown to be effective. Now, another medication is another medication that we use in psychiatry as a mood stabilizer. So this is a medication that's also used in management of migraine headaches and management of seizure disorders. Now, Topamax is something that I've used extensively in management of even aggressiveness. So I have patients who come in with anxiety, irritable mood, agitation, and they're not able to take all the medications. I find that topiramate, which treatment Topmax, has been very beneficial, used to reduce cocaine cravings, and also it can treat a co-occurring use of alcohol. So 2 for 1. So a patient that comes in, I have a patient actually that I saw just today. Alcohol and cocaine is two preferred substance, and he says, when he uses cocaine, he doesn't. He says, well, I was proud to tell me, well, I don't sniff it, I smoke it. And when I smoke it, I chase it down with alcohol, and what he does is 1 pint of vodka daily. So, is this a patient that would benefit from Topamax? Certainly. Now, this was a patient that was also prescribed and recommended naltrexone and Vivitrol, and for some reason he was candid in telling me that even with the naltrexone, he was able to drink on it. So, um, like I said, looking outside of the box, what else can we put in place that may help a patient like that? So, Topamax and an extended release mixed amphetamine salt, like Adderall, Ritalin can be used to reduce cocaine use and cravings, and also can be used with patients who have a co-occurring ADHD. So now, care should be taken when it comes to using some of these medications. So if a stimulant-induced psychosis or mania is expected, we want to make sure that there's a gradual taper off of antipsychotic medication. Because when the patient is agitated and psychotic, it kind of exacerbates their risk. And so the last medication in this slide is one that a lot of people may not be familiar with. So if you're familiar with it, I'm happy. It's called modafinil. So modafinil is also known as Nuvigil. I don't know if anybody has ever heard of it. Nuvigil Provigil. My neurology background, I'm a little more like, I think I like this medication more than most of the other stimulant medication that can be used. Wellbutrin, by far, I feel is safe and definitely beneficial. But I like modafinil. It's not been used a lot because it's expensive, I believe, and a lot of insurance do not cover it. But I've seen some of my patients who also have neurological deficit use it. So I don't know if you guys remember the fighter pilots in the war, like when they have people who have sleep wake problems, like they need to be awake during the day. So modafinil, the first time that I saw that it was used was for patients with multiple sclerosis who have daytime fatigue and drowsiness, and they're not able to stay awake to complete a task. Modafinil is something that neurologists use very well. Now, modafinil is now being shown because of the stimulating effect to be helpful in reducing stimulant craving. Now, one thing that I would like to find out more is when compared to other stimulants, which has a problem of its own. So I always look at this way, like, I mean, we want to minimize risk. You don't want to prescribe a medication for a patient that is going to exacerbate their addiction. I mean, being cautious. So a patient that drinks alcohol, for example, and says, well, I have anxiety, and I think the only medication that would help me for my anxiety is Ativan and Xanax. You want to be very careful that you're not treating one disorder and creating another addiction on the other hand. Modafinil, as a matter of fact, I feel is has a less propensity for dependency, which is what I feel is most critical. I mean, I don't want to say, well, you've stopped using cocaine, but now you're dependent on something else that's going to be a problem for you, and it's going to affect your day-to-day activities. So, I think that's a medication that I think needs to be looked at a lot closer. Next slide. So now, amphetamine type. So we talked about cocaine, and another stimulant that is prevalently used is amphetamine. So amphetamine, meth, crystal meth is another stimulant used that can be managed well with Wellbutrin, with Topamax. Now, a study was done a few years ago with a population, LBGT population, who frequently used methamphetamine. And it was shown that when they were given mirtazapine, which is Remeron, I mean, so anecdotally, I see patients ask me, I mean, sometimes you don't put it together. I see a patient ask me for Remeron, and I said, why? Why is Remeron so popular amongst our patients? So mirtazapine, also known as Remeron, has been used to promote and reduce the use of meth, especially when patients have depression as well. Now, a lot of our patients also with stimulant use disorder, they're coming in. Some of the issue that they would complain of is that they're not sleeping. Oh, I've been here. I'm not able to sleep, and I'm depressed because they've been stimulated too much. Now their body is wired. Now, Remeron is a medication that's been shown specifically not for cocaine, but specifically for meth use. This promotes reduced use, so patients who take Remeron have been noted to have a reduction in their use of meth, especially when their use is very moderate or higher in frequency. Now, one of the things, the last bullet there says that as providers, when you're prescribing medications, the PDMP, which is where we go to look to see what other medications a patient is being prescribed. It's important for us to do the due diligence and just go back and look and ensure that the patient that you're prescribing any of these medications are not on any other stimulant. I find that a lot of our patients, with good intentions, they're not very good at self-disclosure. So I'm seeing a patient this morning and I'm asking him questions about his prior medical history, what he's gone through, and he's being very cagey and not, upcoming about telling me. I think one thing that we're doing better now at Integrity House, and I think it's been an improvement, is we're getting a lot of the records from referral sources. And I think the more information we have, the better. So I have the patient's hospital record on one side, I'm talking to the patient on the other side, and he's telling me something that I feel conflicts with, and I'm telling him, and he's like, "Oh yeah, yeah, I remember now." I said, "You know, are you on this medication?" "Oh yeah, yeah, yeah. Now I know." And he's looking at me like I'm a genius. Like, how are you figuring this things out? I'm like, no, because it's right here, you know, in your medical record. So I think doing our due diligence is important. An experience that I had prior to the New Jersey mandating that every provider utilize this method is when I was seeing a patient private in my private office that I've been seeing for years, and she was taking Ativan that I was prescribing, and was also going to another provider and getting another medication. And thanks to the diligence of the pharmacy at the point, we just decided and say, hey, let me just call the provider. And the pharmacy calls me and said, well, do you realize that your patient is also on this medication? And I'm like, well, so now we have an opportunity to be able to ensure that we're looking at what the patients are on. Overall, our goal is patient care and patient safety. We want to reduce use. We want to promote life. We don't want our patients to die. So what are some of the things that we can give them that would eliminate the cravings and ensure that they live a fulfilling life in the community, which majority of our patients, that's what they desire. And they require that help, which we have. And the more tools that we have in our arsenal, the better care that we can provide. Now, the next slide. Now, so what are some of the special considerations? So, special considerations when we're preparing patients and when we're preparing to administer these medications should be given to adolescents and young adults. So as clinicians, before we prescribe medications that are stimulating, even in the treatment of stimulant use disorder, adolescents and young adults, we need to ensure that there is a parental consent. So if we're treating patients younger than 18, we need to get a buy-in from their parents to ensure that the patient, these kids are being monitored. We need to ensure that there is a trusted adult to observe the administration of medication. So, is the young adult or adolescent, are they taking the medications as prescribed? I mean, people do strange things. I used to treat young kids who are in high school, and they will say, well, I took Adderall. I'm like, well, it's not prescribed. Well, my friend at school shared some of the ones that he had with me. So those are things that we need to be very careful of. Family should be counseled on safe storage. If young adults have been given this medication, we need to make sure that it's stored well. We need to monitor for signs and symptoms of ADHD and eating disorder. ADHD is specific because some of these medications are being used concurrently to manage ADHD. But eating disorder, two medications that I will be very mindful of. The stimulant medication like Adderall, in young adults have been known to decrease appetite and stunt growth. So, so when a patient is being prescribed those medications, you want to make sure, are they seeing a dietitian? How is their appetite? Now, conversely, with the Remeron, the issue that you might have there is that the overeating and increased appetite and weight gain. So this is I've not seen young adults in more than 10 years, but it's a passion for me. And one of the reasons why I stopped seeing young adults is because the parents were not compliant. The kids were great. They wanted the care. Well, I had a young kid, I think he was about 9 years old, great soccer player, but ADHD, hyper, very hyperactive, couldn't stay still in school, but he was very active, even at home. He played soccer, he did. So we started him on Concetta, which is an ADHD medication, did phenomenally well. You know, he was able to focus, he was able to concentrate. Then the mom came and said, well, Bobby is not eating, he's losing weight. I said, oh, wow, okay. We have, as providers, if you're a carpenter, every problem for you could be fixed with a hammer almost. So I said, oh yeah, so let's put him on Remeron. 1 month, oh, he's eating well, he's doing. 3 months later, the mom says, well, he's not taking any of those medications. Why? Because he's gained 20 pounds. Now, he's not able to do as well in his soccer practice. So those are some of the things that we need to be very careful about. And another thing, when we're prescribing stimulant medication, there has to be a concurrent management with the medical. So what are some of the medical workup that's been done? So patients on stimulants needs to get an EKG prior to the initiation of those medications, and routinely once you've started them on that medication. Another special consideration: pregnant and postpartum women. Definitely, I've had a lot of patients that I've seen through my practice here at Integrity who either come in pregnant, and they need to stay on their medication. So we need to make referrals as appropriate and ensure that we're managing this client with OBGYN, making sure that the prenatal care providers are also being kept abreast of whatever interventions that we're given. We need to educate patients that they should not actively breastfeed if they're actively using stimulant. So what kind of medications can the patient be on if they're breastfeeding? So those are some of the considerations that we need to take. Next. Now, back to some of the things that we've been doing, and I think has worked in terms of interventions, therapeutic intervention. When we care for patients, I think it shouldn't be heavily weighted on medications, and neither should it be just, psychotherapy. I think patients are best managed when there's a collaboration. I tell my patients all the time who are not going to therapy, I said, your best, getting the best bang for your buck is when you have therapy and you also marry it with medication. So it's not a one-way approach. So, I mean, I always refer, and our therapists there have been phenomenal. I mean, about the patients that I have, especially those in the outpatient setting, that have done the best are the ones that have therapy that is consistent. So one of the approach in managing stimulant is a therapeutic management called contingency management. And what is contingency management? It is an intervention that uses rewards and incentives to reinforce positive behavior that is related to treatment, participation, and outcome. And it allows patients to be able to remain engaged in treatment. So when the patient is being reinforced, like, well, yes, you're doing well, you've been clean for 6 months, you've been clean for a year, and either verbal reinforcement or doing things for them, like educating them or bringing them out, and just to kind of celebrate their accomplishment. So this has been proven to be most effective in comparison to any other intervention. So research has actually shown that it is effective with abstaining from substances, with medication compliance, with participation in treatment. I have a lot of our patients who have been discharged, and one of the things they look forward to is the day that they can come back to Integrity House and speak to other clients. And I think some of these things should be done. Maybe we need to bring our patients, track them on how successful they are, bring them back, and maybe celebrate them, give a cash prize, an award, a gift card, or voucher. This thing goes a long way. I mean, something that breaks my heart is when I have patients who are doing well and they would say, well, I didn't pick up my medication because I can't afford the copay. I think some things that we can do, like, oh, well, it's either I go get some food or I go take my medication. So something as small as $20 could prevent a patient from, obtaining the medication that they need. So cash prize, a gift card or a voucher that they can say, well, maybe you can use this for those times when you need to pay like a $5 copay for your medication. I mean, so most of us, we may say, well, come on, man, you wouldn't take a medication because of $10, but for a lot of the patients that we care for, $10 could maybe significant. So I think this kind of reward, or a patient comes in subsequently, negative urine drug test, and you say, okay, you've been coming here for 5 months now, and your urine test has been negative. Here's a $25 Wawa gift card. Okay, we're encouraging the patient to manage this disease that is prevalent, and then we're doing something about it. So that's contingency management. And the next, community reinforcement approach. I believe that the approach at Integrity House is definitely a community approach, from as inpatient to outpatient to now having our mobile clinic. I think we're becoming more visible in the community that we serve, and we're making a difference. So with this behavioral therapy approach, clinicians work closely with the patients to adjust certain components of their life that may impede with their healthy living. So we work to build the lives without the use of substances that is more rewarding to them. So, organizing things in the community, having patients come back to the IOP. We have the STAR program. What are some of the things that we're doing to reinforce sobriety? This has also been shown to be effective in treating patients specifically with cocaine use. And it's led to a higher rate of abstinence. What are some of the barriers to this? Staff commitment. Our staff trained to meet the needs of this consumers. I think when we have those patients on our grounds, I think it's easier. We can say, well, we kind of like monitor their day to day when they get their medication, what intervention. But I think a more difficult approach is when they are outside in the community. Because I see patients who do well in the short term, in the long term, in the halfway house until they get to that community where all of a sudden there's nobody holding them accountable. They're missing appointments, and the medication is not as important. For me, a trigger is when a patient is an inpatient and wants to be on all the medications, and as soon as they get to the halfway house or they're nearing discharge from the halfway house, they come to you and says, "Oh wow, all the problems I told you I was having, I'm no longer having them. I want to come off of those medications." For me, that gives me like okay, what's going on here? So I think at that point we should look at that as an opportunity to re-educate. So is it because you didn't need the medication in the beginning, or because now you're going to be out in the community and you're going to have access to something that you may want? So I think our work is not done once the patient leave our establishment. That's the point. That there should be a way that we continue to engage with them. Our outpatient clinic, CCBHC particularly, I think we're looking to bridge that gap now. So some of the patients that are discharged from our inpatient settings are also going and seeing the same provider. So there's a continuity and of care. So I think that's something that as providers, we need to be more committed to ensuring that those patients, that the next time we see the patient is not when they present back, to the short term. I think we need to continue to bridge that gap, and we have our work cut out for us, but I think we're definitely up to the task. So the next one. Now, we talked about cognitive behavioral therapy. CBT, we know, is widely used as a treatment modality in depression, anxiety, but it also can be used in stimulant use because it addresses thoughts, emotions, and expectations and allows our patients to change a lifestyle. I think that's what cognitive behavioral therapy is about. Changing the cognition, changing behavior. So when you say people avoiding places, people, places, and things, I mean, avoiding those behaviors, avoiding triggers, how are you managing those negative emotion? So it's not a light switch. You can say, well, let's take this medication and see me tomorrow. Well, how can you change those behaviors also, those triggers? What are some of the things that are perpetuating your continued use? And how can we help you? How can we teach you that there are other ways to cope when you have triggers? And triggers are going to come. You know, as sure as paying taxes is, there are going to be triggers no matter what medications you're going to be on. I have a patient when we were coming to Newark, one of this, I still see her till today in a different setting. And she will say to me that the way that she realized that she's doing well and she's getting better was that when she's walking from a halfway house to come to the medical building in Newark to see me, that on our way there, this was prior to COVID, this was in 2017, 2018, that prior to coming there, on our way there, she's been stopped like 3 times by somebody on the street who offered her cocaine. As she was walking, just coming, somebody was, oh, and they said, oh, you don't have to pay for it. And they know that they could tell that she's probably in a treatment program, that the way she knew that she was doing better was because she didn't succumb to that. Like in the past, she would have just said, okay. So that's a behavior that's changed. And it's a determination that she's made. And I think that's where medication would help. But I think therapy also, educating the patient, this CBT therapy, I think there's a key there. There's a key there. And I think we need to change those behavior, change those feelings, and try to re-educate that thought process so that when confronted with triggers, when confronted with challenges, that our patients are going to be able to make the right choices. They're going to be able to make the right decision. And I think that's crucial. And we shouldn't say, well, they're just on medications. Let's not do therapy. No, I think our therapists are, to me, like gold. I think we need to nourish their experiences, and then we need to kind of whatever collaboration they need. I mean, the best therapists that I've worked with are therapists that have actually called me and said, oh, what can we do with this patient? What can we do for this patient? And that shows that we have, we're working in a multi-disciplinary approach and treating the patient in a holistic manner, not just as a number, but as a person that overall we want to make sure that they get to their destination, which is recovery. Next. Now, the matrix model is another one. It's a behavioral therapy that offers counseling, similar to what we've discussed, CBT. But I like the part of the family education and the support group, which I think is what should be the engage in the family also. Support group, having a support system that our clients can participate in, whether internal or external when they leave, attending groups. I think support groups and family hold patients accountable. I find that the patients that have a solid support group, a solid family, social group, they do better because there are people that are holding them accountable. And they're not just embarking on the recovery process just for themselves. They're doing it, oh, I have my child. I have my mother that I want to make proud. I have, I want to be reunited with my family. So I'm not just doing it for myself. So, and I engage in the family as well. And ensuring that there are a support system goes a long way in managing substance use, specifically stimulant. So this matrix model has been shown to have great outcomes for the management of methamphetamine use and helping reduce risky cravings, which leads to a risky behavior. The matrix model has helped patients obtain necessary information to create a healthy lifestyle and the support system to abstain from substances. Now, referral and education. How do we get patients to another level of care? So as clinicians, we need to make appropriate referrals to primary care. So a lot of our patients are coming in and they have comorbidities, We talk, some of them are diabetic, some of them are dental problems. What are some of the issues that stimulant use can precipitate in terms of medical? So cardiac problems, endocarditis, dental care. So if we have patients, I mean, when you look good, you feel good. If our patients are struggling with that have struggled and battled with addiction, being able to regain their confidence that they've lost from an extended period of drug use, being able to give them their life back. Is it referring them to a dental provider, referring them to like a cardiologist, making sure that there's things that they need that they can get back to the life that they. Nutrition is important. Having a nutritionist to educate them, are they consuming the right food? And referring for harm reduction clinics for safe injection supply. Because at the end of the day, you're going to find that even with all our interventions, there are still going to be instances where there are patients who are going to, fall off the, and may use. So how do we promote safe use? And at the point where ultimately they can give up the use. So referral and education is definitely critical. And I think working in a collaborative, looking also in our community, who are some of our stakeholders, our supporters, who are people that are referring patients to us? And are we able to refer patients to them as well? I think that makes a big difference in ensuring that this epidemic is managed. Next. So the harm reduction strategy, it gets to a point where we're not only trying to ensure that the patients are not using, we want to ensure that they're safe, that patients are safe. So as clinicians, we need to tailor our educational strategies for our patients in relation to their pattern of use. So someone would say, well, you're meeting the patient at the point of their need. And so no two patients are going to present the same. So a patient may come to you and say, well, yes, I'm ready, and you do everything that is necessary. And a patient may still need to be slow walked and say, well, you're going to be ready, maybe not now, but, and I think one of the things that we don't want to do is to kind of short our patient off and say, well, you don't want to take. So if a patient tells me, I'm not interested in MAT, I'm not going to look at it and say, well, this is not a patient that is not interested in recovery. And I would just say this is a patient that is not ready yet. The fact that the patient is at my door talking to me shows some attempt, maybe not, to the point where they want to give up use completely, but how do we guide them? And by guiding them, our goal is the harm reduction. So patients will say, well, I no longer need Suboxone. I think I'm good. I've been clean I don't want to be addicted to something else. This is just, I said, well, if you're going to take something, I'd rather you take something that you're not going to die from. So I'd rather you, take something that would allow you to be able to live a normal life. One of my greatest patient story that I've shared is a 33-year-old woman who used cocaine and also used heroin and has been on Suboxone now for 5 years. And she has a job at one of a large chain supermarket, uh, actually in human resources. And I make every attempt to make sure that she gets what she needs because I realize that she struggles and the intervention that she's taking is actually ensuring her to leave. She got married 2 years ago, and every time she comes on the screen and I see her, I mean, it just kind of warms my heart that somebody, she knows that I need this medication because it keeps me functioning and it allows me to stay alive for my daughter, for my granddaughter. So as clinicians, we need to be able to offer education about safer stimulant use if the patient is still going to use stimulants. How do you how do you prevent overdose? Safe sexual practices. We know that with methamphetamine use, there's that inclination to be a little outlandish and not and be impulsive. Performing comprehensive drug testing via fentanyl testing strips. So those are some of the harm reduction strategies. When I give this presentation at another event, one of the things that I said was that you know a lot of patients who use stimulant, they wouldn't even, if they're using stimulant, they probably wouldn't even tell you because they some I mean, I think I'm going on a limb here when I say some patients do enjoy it. I think, people want, the effect of the stimulant. So that's why a lot of stimulant users are not so prone to seek help because it's something that they want. It's something that they enjoy. I listen to, I'm a music lover and there's a music I've been listening to for years and I never really realized, how you listen to some music and you don't realize that they're actually talking about drugs. I remember the song, if you guys may know the song by Jay-Z and Alicia Keys called New York. And it was after I did this presentation, I listened to that and I heard Jay-Z say something about MDMA make you feeling like a champion. I'm like, really? Are you kidding me? So that's why people want to use because they feel like a champion, but it's only short-lived. So stimulant use is very pervasive in our culture, in our community, and I think we need to kind of as much as attention as we give into alcohol use and heroin use, we need to pay such attention as well to stimulant use. Next. Now, this is the references. One thing that I don't have on the slide, but I wanted us to share, and if you guys have any questions, I will take the questions. Is the fact that I see some questions. So is the fact that there may be challenges. So when we talk about all these medications that I've listed, so let's just recap. So we talked about Wellbutrin, we talked about Topamax, we talked about mirtazapine, modafinil, and some of the ones we touched on but not elaborately are the Adderall and you know Adderall and Ritalin and medications like that, which in the studies were also shown to have been beneficial, especially if there's a co-occurrent ADHD. But what are some of the challenges that I find? I think some of the challenges that I find is that, attitudes of providers as well. We want to be sure that we're prescribing medications for our patients that they're not going to be, hooked on again. So, case in point, I'm going to use it. So this was a patient that I saw earlier. So this is a 41-year-old patient who presents with a history of ADHD and said, he started using meth. And I said, how did you arrive at meth? He said, well, somebody gave me, I was getting, in his word, I was getting a very large amount of Adderall. And, from that Adderall, I progressed to methamphetamine. So how could that be a challenge in terms of this medication that we are prescribing? You want to be sure that whatever medications we're prescribing to treat a condition is not inadvertently creating another, addiction. So I think that's where we need as providers to be able to look at it as on a patient by patient basis. So I wouldn't say, well, let's go gangbusters and just prescribe everybody that is using cocaine, stimulant. No, I think we need to have a more guided approach and say who are some of the patients that may benefit from Wellbutrin, for example. I mean, I think we should start at the ones that are more less likely to be addictive, which anything can be addictive. We've had instances in our inpatient setting where we have patients who abuse Wellbutrin, and to an extent where we actually started saying, well, maybe patients shouldn't be getting Wellbutrin, but I think we don't want to throw away the baby with the bathwater. So we want to say, well, a judicious approach and saying, like, let's work with the patient. What are some of the things that we can prescribe? And out of all the medications that have been enumerated, which ones could be less addictive? And let's start with that. But I think, it just gives us another tool. And that's the opportunity that I believe we have now. When somebody shows up at our doorstep with stimulant use disorder, that it's not just like, well, we can't give them. Are we using enough of the Remerons? Are we using enough of the Wellbutrin? Are we using enough of the Topamax? We can start there and see, and using all the other behavioral approaches and ensuring that ultimately our patients are getting the best care. So I'm going to go over some of the questions quickly. So if a drug like Wellbutrin is not FDA approved for treating cocaine use disorder, is it allowed to be prescribed for this condition? Yes. I mean, off-label, it can. And that's what's been done. And how do we implement these strategies with patients whose goal is not abstinence? So that's one of the key points when I said meeting the patients where they are. So if a patient has determined that, well, I don't want to be abstinent, so there cannot be a concurrent. So if a patient tells you, I still want to be able to use cocaine, then that kind of answers your question. Then the patient is not, giving them Wellbutrin unless they have. You're not going to decide not to treat their other diseases. So if a patient has ADHD or has depression and is taking Wellbutrin, but also uses cocaine, you're not going to say, well, I'm not going to give you that medication. You're going to hope that hopefully, their craving or their use of the stimulant will be diminished. Similar to someone that smokes and says, well, I still want to be able to smoke cigarette. I don't want to give up cigarette, but should I be able to take Wellbutrin? Yes. Would the Wellbutrin allow you to go from a pack a day to maybe a few cigarettes a day? I would say yes. The ultimate goal is abstinence, but abstinence does not automatically go from using 10 bags of heroin to 0 bags. Sometimes it may be, a gradual decrease. And I think that's where that's how we have to look at our patient as an individual. Is it possible to have slides available? Yes, it is possible, and the slides will be provided. So thank you so much for giving me this opportunity to present. I hope that this was informative. I enjoyed putting it together, and I look forward to us collaborating in the patient care. So those of us that are Integrity House affiliated, you can get my email address, and if you need to ask me questions specifically about patients that you're seeing or generally, definitely feel free, and I'll enjoy answering your questions. Thank you so much.